Now let's start with forearm fractures, the fractures that occur in the forearm. But quickly review what is forearm basically. The bones in the forearm. The two important bones, or the two only bones in your forearm, is your radius and ulna, right? So this is radius and ulna. This is the volar aspect that I'm showing you, radius and ulna. Right, so ulna is supposed to be a straight bone over which the radius will rotate, giving you the movement of supination and pronation. Okay, movement of supination, pronation. Now there are two important joints here. One is at the proximal radio-ulnar joint, and the other is at the distal end, the distal radio-ulnar joint. And the radius and ulna are connected to each other with something known as interosseous membrane. So between bones, osseous is bone, membrane, that is the membrane between the bones. So interosseous membranes. Okay, so quickly again see what I've told you about. I've told you about the radio-ulnar joint, the proximal and the distal. I've told you about the interosseous membrane, and this complex helps basically supinate and pronate. Radius rotates over ulna, which is usually straight. That is what I wanted to understand. Okay, so with this normal anatomy in mind, we'll talk about the fractures that occur at the forearm first. So we'll talk about the forearm fractures, and then we'll move on to the distal end of the radius. So look at this. What is this fracture? This is an AP. And this is a lateral view of the forearm. You can clearly see that the radius is fractured and ulna is fractured. And in lateral view also you will see both bones are fractured. This is called as the both bone forearm fracture. Both bones of the forearm fracture. A very common fracture nevertheless. And based on our algorithm that we read in the basics of orthopedics, what is the treatment? You can manage it conservatively with closed reduction POP application, or you can go with open reduction internal fixation with plates. Now the question arises, if you're going to use a POP, in which position will you keep the forearm? Obviously, we know that if you apply the POP, based on the principles of POP, we have to apply the cast, immobilizing the joint above and the joint below the fracture. But in which position will we apply? So suppose there is an upper 1/3 both bones forearm fracture, middle 1/3 both bones forearm fracture, and distal 1/3 both bones forearm fracture. You can immobilize these fractures differently. So proximal 1/3 is basically immobilized in supination, that is in full supination. Middle 1/3 is in mid-prone position, and distal 1/3 is in a prone position. This is what I was talking about. So upper 1/3, middle 1/3, and distal 1/3 of forearm fractures can be immobilized conservatively like this with the POP. Now, how do you remember this? If you recall, proximally you have a muscle known as supinator, right? So supinator for proximal 1/3 fractures, and distally you have something known as the pronator quadratus. So distal fractures, you will keep it in pronation, and middle fractures you keep in mid-prone position. Just remember basic MCQs that can be answered. Right, now let's look at this slide. This is an X-ray, and what do you see on X-ray? There is a fracture of which bone? There is a fracture of ulna, right? And there is a dislocation of the radial head. So this is an ulnar fracture with a radial head dislocation. Have you heard of this combination of injury? Yes. This is your Monteggia fracture. It's a fracture of the upper 1/3 ulnar diaphysis with the radial head dislocation. Classical. Upper 1/3 ulnar diaphysis with radial head dislocation. This is your Monteggia fracture. Very, very important for your exam. Very commonly asked. Okay, are you able to assess this and identify it on X-ray? Now, there is a classification for Monteggia fracture. It's called as Bardo classification. Now, trust me, it looks overwhelming, but I'll simplify it for you. So, in type 1, there is an ulnar fracture with radial head dislocation anteriorly. Type 2, there is an ulnar fracture with radial head dislocation posteriorly. Type 3, there is an ulnar fracture with radial head dislocation laterally. And in type 4, both ulnar and radius fractures with radial head dislocation anteriorly. Now, this looks confusing, but I'll simplify it for you. In all the types of Bardo, 1, 2, 3, 4, ulna is fractured. That is a taken. That is a granted. Okay. Second common thing is all the types of Bardo, 1, 2, 3, 4, radial head is dislocated. Now, depending on where it dislocates, we have 1, 2, 3. 1, it dislocates anteriorly. 2, it dislocates posteriorly. 3, it dislocates laterally. Now, what about in 4? In 4, again, it dislocates anteriorly, but this time with a fracture. Again, that's all. So, type 1 is the most common, and this is the table that will help you remember the classification. Ulna is fractured in all of them. But in type 4, radius is also fractured, and radial head is dislocated in all of them. In type 1 it's anterior, type 2 it's posterior, type 3 it's lateral, and type 4 again with the fracture it is dislocated anterior. Very simple classification. Now, can you tell me from the basics what would be the treatment of Monteggia fracture? If you recall, Monteggia fracture is a fracture of necessity which requires or necessitates surgery. So the treatment will be open reduction, internal fixation with plates. And which bone will you plate? You will plate your ulna, and usually radial head will fall into place. First thing. Second thing, can it be managed conservatively? Absolutely not, because it's a fracture of necessity. And the third thing I wanted to know is, what is the most commonly injured nerve in Monteggia fracture? For that, I want you to recall which nerves wraps around the radial head. There is a nerve that wraps around the radial head, around the radial neck. Which nerve is that? Yes, it is the posterior interosseous nerve, and that is the nerve that is most likely injured in Monteggia fracture. Can you recall what is the clinical presentation of posterior interosseous nerve palsy? Yes, the patient will have no sensory deficit, but will have finger and thumb drop. Excellent, right? So, most commonly injured nerve is posterior interosseous nerve. The treatment is open reduction, internal fixation with plates. Other MCQs that I would like to ask, again to review what we have been reading so far. What is the most commonly injured nerve in shoulder dislocation? Come on, you know this? Yes, axillary nerve. Yes. What is the most common nerve injured in supracondylar humerus fracture? Yes, anterior interosseous nerve more than median nerve. And remember, anterior interosseous nerve is a branch of median nerve, whereas posterior interosseous nerve is a branch of radial nerve. Excellent. Okay, na? Again, let me show you one of my patients. This is a fracture of ulna with radial head dislocation. Fracture ulna, radial head dislocation. I openly reduced, internally fixed the ulna, and radial head should have gone inside, but it was not, so I had to use a K-wire. But otherwise, at your level, just remember, you will fix the ulna, and the radial head usually goes back into place. Okay, that is Monteggia fracture, a very, very important fracture for your exam. Now look at this. Can you tell me what this is? There is a fracture of the radius with the distal radioulnar joint getting disrupted. You can clearly see that it is disrupted in AP view, and you can also see that it is disrupted in the lateral view. So there is a fracture of the lower 1/3 of the radial diaphysis with the distal radioulnar joint getting disrupted. This combination of fracture is known as reverse of Monteggia or Galeazzi fracture, also known as Piedmont's fracture. Again, another fracture of necessity, very, very important fracture for your exam. It's a dislocation or subluxation of the distal radioulnar joint in association with a fracture of the radius. Now, please remember, when the ulna DRUJ is disrupted, that the distal radioulnar joint is disrupted, the ulna dorsally migrates like this. So clinically, a patient will come to you with a dorsal disposition of ulna, and you can press on it clinically like this, and that has been described as a piano key sign. Now, can you tell me what would be the treatment of Galeazzi fracture? Just based on the algorithm, because it's a fracture of necessity, ulna is dislocated. Yes, so the fixation is radial. So open reduction, internal fixation of the radius, and usually the DRUJ will stabilize itself. If not, then you can put a K-wire in it. Okay, that is there. Now there is one thing I want you to understand is this distal radioulnar joint. This distal radioulnar joint is basically stabilized by something special known as triangular fibrocartilage complex. Okay, it is this triangular structure that will stabilize the distal radioulnar joint. So whenever the distal radioulnar joint is disrupted, friends, automatically it is assumed that the TFCC is injured. So sometimes on your exam, the examiner will tell you that Galeazzi fracture is nothing but a fracture of the radius diaphysis with a TFCC injury. If that is the case, yes, it's a true statement, because DRUJ disruption is equal to a TFCC injury, and that is the same thing. So usually the TFCC would be somewhere over here at the distal radioulnar joint, and it's the shape of a triangle. We call it a triangular fibrocartilage complex. Now, moving on to Essex-Lopresti injury or Essex-Lopresti fracture. It's a very straightforward, simple fracture. What happens is the patient falls on an outstretched hand, and there is an axial loading of the forearm bones. Now, when there is an axial loading of the forearm bones, friends, what will happen is the DRUJ, the distal radioulnar joint, will be disrupted. The radial head will get comminuted or fractured. So there is a radial head fracture, proximal radioulnar joint disruption, distal radioulnar joint disruption. And when this happens, the forearm bones lose their alignment. And when they lose their alignment, the interosseous membrane between them also gets torn. Okay, when the alignment is disturbed, the interosseous membrane is torn, right? So this combination of injuries is what is known as Essex-Lopresti injury or Essex-Lopresti fracture. It occurs because of axial loading. There is a radial head fracture, DRUJ gets disrupted, and there is a tear in the interosseous membrane. Now, usually the treatment is you cannot fix the radial head because it is comminuted and destroyed. So in adults, we will actually go for a radial head excision, but this is avoided in children because you need the radial head in children, because if the radial head is excised in children, there will be an abnormal growth of forearm bones, which will cause a limb length discrepancy and deformities. That is why radial head is salvaged or tried to be protected, and excision is avoided in pediatric age groups. Now, can you diagnose this fracture over here? Yeah. So look at this. This is an X-ray of your forearm. Yeah. And you can clearly see the radius is absolutely normal. And there is an isolated fracture of ulna. Isolated fracture of ulna. What is this, friends? This is your typical nightstick fracture. Do you know what nightstick is? Nightstick. This is nightstick. This is the stick that is carried by policemen and security guards to hit offenders or someone. And it is called nightstick in the day and afternoon also. It has the name nightstick. That's all. Okay, it's just called nightstick. Even in the morning, it's called nightstick. Anyways, so I want you to remember this nightstick fracture as a specialty fracture where this occurs because of self-defense. Somebody tries to assault you and you defend yourself. So if somebody tries to assault you with a stick, how do you defend yourself? How do you usually defend yourself? You defend yourself like this. And when you defend yourself like this, the stick will come and hit your ulna. So isolated ulna fracture is a self-defense injury. This is your nightstick fracture. So direct trauma of the forearm while in defensive stance. It's a self-defense injury. It's an isolated ulna fracture without radius or any other fracture. So how will you treat it now? Based on the algorithm, close reduction POP application or open reduction internal fixation with plates. Now coming to the fractures of the distal end of the radius. So our story for forearm fractures is over now. We are moved into the distal end of the radius here. See, when I say forearm, I was talking mostly about the diaphyseal bone. Now we have moved into the metaphyseal bone, or the bone where there is a cortico-cancellous junction. This part, very, very important, very, very interesting for your exams as well. So all the fractures that occur at the distal end of the radius were basically classified and described by someone known as Abraham Colles, very smart orthopedic surgeon, also an anatomist. He used to injure dead bodies. He would make these dead bodies fall into a particular position and attitude, and then he would study how these fractures would present clinically. Very interesting story. Anyways, so the classification of distal end of the radius fractures were given by him. We have Colles fractures, we have Smith's fracture, we have Barton's fracture, and we have Schoffer's fracture. Among the many that he has described, these four are very important for your exam. But before I go and explain each of them in detail, the essential point is you need to review the anatomy, without which you will be lost and confused. So let's quickly review the anatomy of the distal end of the radius. Now, if you look carefully, what do you notice? Before looking at the X-ray, look at this. The distal end of the radius. Okay, pay attention. Focus with me. The distal end of the radius. Okay, so this is like this right now, like this. The distal end of the radius, the articular surface, is very unique and special in a way that it faces volar side. Okay, it faces the volar side. I've told you, it's like this. So this side is the volar side, the palmar side. This is volar, palmar, ventral, anterior side. It faces that. And also it is facing towards the ulna. So let me show you in AP view. The distal end of the radius faces towards ulna, and in lateral view, it is slightly palmar and volar. And how can you identify it's palmar and volar? Look at the thumb. So normally, this is where the thumb is. Thumb is in the direction of the palm or the volar. So it will face palmarly or volarly. This is the articular surface, smooth. Okay, can you appreciate that? I'll remove the marking so that it is easy for you to grasp. Okay, right. So whenever you get a fracture of the distal end of the radius, the first thing I want you to do is identify whether the fracture is extra-articular or intra-articular. So this is again image of the radius, distal end, lateral view. So identify whether the fracture is intra-articular or extra-articular. So these are extra-articular fractures, and this is intra-articular fracture. Okay. Now that you have identified which is extra-articular, which is intra-articular, the next step is to identify what happens to the distal fragment in extra-articular fractures. So here the extra-articular fragment, the extra-articular fracture, distal fragment is moved dorsally. Here it is moved ventrally. If an extra-articular fracture displaces dorsally, remember it is Colles fracture. If the extra-articular fracture displaces ventrally, remember it's reverse Colles or Smith's fracture. And if it's an intra-articular fracture that you're able to see in the lateral view, it is usually Barton's fracture. Okay, depending on the rim, small rim on the dorsal side, dorsal Barton, small rim on the ventral side, ventral Barton. So this is dorsal Barton and this is ventral Barton. Nevertheless, just remember it is Barton. So intra-articular fracture, Barton's; extra-articular fracture, dorsally displaced Colles; ventrally displaced Smith's. Your life becomes easy. I've told you, you have to make the diagnosis. After making the diagnosis, everything becomes easy. Okay, you have made the diagnosis. So quickly sum it up. I have made a table for you so that you can write it easily. Extra-articular fractures are dorsal and ventrally displaced. If it is dorsally displaced, it is Colles fracture. If it is ventrally displaced, it is Smith's fracture. And if it's intra-articular fracture with a dorsal or ventral lip, it is Barton's fracture. And an isolated radial styloid fracture is a Schoffer's fracture, which I'll describe in a bit. Don't worry about it just yet. So forget this for now. Just focus on extra-articular versus intra-articular fracture. Extra-articular fracture, dorsally displaced, Colles. Extra-articular fracture, ventrally displaced, it is Smith's fracture. Intra-articular fracture seen on lateral view is Barton's fracture. Depending on it dislocates and subluxates dorsally, we call it a dorsal Barton. Dislocates and subluxates ventrally, we call it ventral Barton. I'll show you how. Don't worry. Okay. Now look at this X-ray and tell me what it is. X-ray of the distal end of the wrist. Extra-articular fracture. Extra-articular fracture. Distal fragment is facing dorsally. How can you say that? Because normally it is supposed to face the thumb, but here it is facing dorsally. So this is your classical Colles fracture. A few important points about Colles fracture is the most common fracture occurring at the distal end of the radius in old post-menopausal female. Old post-menopausal female. It is a fracture that occurs at the cortico-cancellous junction. Very, very important. Cortico-cancellous junction. It's an extra-articular fracture. What is the mechanism of injury in these elderly females? It is a fall on an outstretched hand, but the wrist will be in extension. Fall on an outstretched hand with wrist in extension. Only then the distal fragment will go dorsally. If the wrist is in flexion, the distal fragment will go ventrally, and that is what happens in Smith's fracture. Okay, that's all. That is all you need to know. Now, what about the displacements of the distal fragment? We already know one important displacement, dorsal. We already know that there is a dorsal displacement. So there is a dorsal tilt and shift. Other displacements are impaction, lateral tilt and shift, and supination. Just remember, the most important one is impaction, but to make the diagnosis, you look for dorsal. Okay, most important one is impaction, but to make the diagnosis, you're looking for the dorsal displacement of the extra-articular fracture fragment. Okay, now this dorsal displacement will classically give you this dinner fork deformity. So clinically, when you look at the patient, examine the patient, there will be swelling at the distal end of the radius, where there will be a classical dinner fork deformity. Now, how will you go about treating this Colles fracture? Since it's an extra-articular fracture, upper limb algorithm matches to close reduction, POP application, or open reduction, internal fixation with plates. Right. So you will go for a close reduction POP application with a below elbow cast. This is an exception to the rule because wherever you use a cast, you immobilize the joint above and joint below. Here, you're not going to immobilize the joint above because I'll talk about it later. So the POP that you use is known as your handshaking cast, where the position of the cast is pronation, ulnar deviation, and flexion. So this is the handshaking position, not this handshaking position. It is this handshaking position actually. That's why we call it the handshaking cast. Okay, not this handshaking jangli wala. It is this proper pronation, ulnar deviation, and flexion. This is the proper handshaking cast. Okay, that is the handshaking cast that you will use. So there is pronation, ulnar deviation, and flexion at the wrist. All other options are you can go for open reduction, internal fixation with plates as well, and all of that will work. Now the question arises, how will you reduce the fracture? The technique of reduction is very simple. You apply traction, and I'll show you a video again, and I have shown this same video in the basics also. You'll apply the traction, and after application of traction, you will provide palmar flexion. Will provide palmar flexion and then do ulnar deviation, so such that the distal fragment will be in palmar flexion and ulnar deviation and pronation. This is the position of the cast. Okay, so traction, palmar flexion, and ulnar deviation, and then you apply the POP cast. Now here I would like to demonstrate this deformity which is in front of you. This is your clear deformity where there is a swelling around the wrist. This is an elderly patient, history of fall on an outstretched hand. This is your dinner fork deformity. Now this is from another angle where you can clearly see a lateral view showing you the classical dinner fork deformity of your Colles fracture, which is an extra-articular fracture of the distal end of the radius. And this is the X-ray of the gentleman trying to show you that there is an extra-articular fracture of the distal end of the radius. And in AP view, you can clearly see it's an extra-articular fracture. And in lateral view also, you can clearly see it's an extra-articular fracture with the distal fragment dorsally displaced. Now, can you quickly recall and tell me what were the deformities or the displacements seen in Colles fracture? There was a dorsal tilt and shift, there was a lateral tilt and shift, there was an impaction, and there was a supination. So the technique of reduction of Colles fracture is basically to counteract or to reduce the fracture in the opposing direction of the displacements that I've just talked about. So dorsal, we need to bring it to volar, and impaction means we need to give traction to reduce the impaction, and lateral deviation means it's radial deviation, so we need to bring it towards the ulnar side, and if it's in supination, we need to bring it into pronation. So let me show you the steps of reduction of Colles fracture. So here there are three people. You know what is being done here. This gentleman over here is providing the traction. That gentleman over there at the end is providing the counter traction. And this gentleman right in the middle is the one basically trying to mold and reduce the fracture into the desired form that we want. So traction is being applied here to reduce which type of deformity? The impaction, right? So to reduce the impaction, we need to give traction. And you can obviously see that the forearm is in pronation already because the supination was a deformity, and so we are bringing the distal fragment into pronation. So pronation is being taken care of by pronating the forearm. So what are we reducing? We are reducing the supination. Traction being provided to basically reduce the impaction. So impaction is being taken care of. Supination is being taken care of by traction and pronation. What are the two things we need? So we need to do palmar flexion to counteract the dorsal tilt, and we also need to do ulnar deviation to correct the lateral shift and tilt. So what else do we need? We need palmar flexion and ulnar deviation. You can clearly see that the doctor in the middle is basically trying to reduce the fracture, while the person providing the traction is giving palmar flexion as well as ulnar deviation. You can clearly see that he's giving palmar flexion now and also ulnar deviation. Now you can see that the doctors over here are holding the wrist in palmar flexion as well as ulnar deviation, and the cast padding or the soft roll has already been applied. Now they are putting the POP slab, that is calcium sulfate hemihydrate mixed with water becomes calcium sulfate dihydrate, and they will apply it on the dorsal aspect of the wrist so that the dorsal tilt does not happen, and the POP acts as a buttress preventing it from displacing dorsally. Then all the while that he's applying it, nobody will remove the traction and the reduction because it will otherwise go back into the displacement. Now the cotton roll or the gauze roll or the roller bandage is being applied to keep the slab in place. Now the doctor is molding the POP to keep the fracture reduced after application of the cotton or the soft roll. And this is the final casting that you can see. This is your hand shaking cast with pronation, ulnar deviation and flexion applied to the wrist. These are the techniques of reduction of Colles fracture. So remember, traction is applied, pronation is done, palmar flexion is done, and ulnar deviation is done, and the POP is applied in hand shaking position. It's not this typical hand shaking position. It's a pronation, ulnar deviation and palmar flexion. It is this hand shaking position, and that is the cast applied. And remember, it is always below elbow because we all know that the most common complication is stiffness of the fingers, and we do not want that stiffness of the fingers to also cause the stiffness of the wrist and the elbow. So the cast is a below elbow cast. So this is the video that I was talking about. So as you could have seen in the video, the first step is to give traction, and then you have to do palmar flexion and then ulnar deviation, and then finally you apply the plaster of Paris. Now coming to the complications of Colles fracture, you recall I told you that in every fracture we immobilize the joint above and below, but we make an exception to this rule in Colles fracture where we put the cast below the elbow. The reason for this is we do not want stiffness at the elbow, because the most common complication of Colles fracture is actually the stiffness of fingers. Very important, because you see, if a patient has a Colles fracture, he will not move the wrist, so wrist might go into stiffness. The most common complication is finger stiffness, and if we immobilize the elbow also, what will happen eventually? Elbow will also become stiff. That's why to minimize that, to mitigate that problem, we use a shorter cast, and that is why the cast is below elbow. Also remember that the most common complication is stiffness of the fingers. Second most common is malunion, the Dinner-Foch deformity. The other complications are complex regional pain syndrome or Sudeck's dystrophy, which is nothing but a reflex sympathetic dystrophy where there is a sympathetic overactivity and discharge around the wrist. There is a rupture of extensor pollicis longus tendon that can occur because of the fracture. The other complication is fracture hematoma can cause compression of the median nerve, the carpal tunnel syndrome. And also recall from the basics that the fracture that is more commonly undergoing malunion rarely undergoes non-union. So non-union is a very, very rare complication of Colles fracture. Now look at this fracture and try to make the diagnosis. Here, articular surface looks fine. There is an extra-articular fracture at the corticocancellous junction. The displacement is volarly. This is your reverse Colles or Smith's fracture. Extra-article, distal end of the radius is volar. Fall on an outstretched hand with wrist in flexion. Very good. The deformity associated with Smith's fracture is garden spade deformity, which is the opposite of a Dinner-Foch deformity. Distal fragment going dorsally, you have your Dinner-Foch deformity, and distal fragment going ventrally or volarly, you have your garden spade deformity. Again, clinically you will notice that this is your garden spade deformity and this is your Dinner-Foch deformity. A very, very important clinical image for your exam. Now look at this. Can you make the diagnosis here? It's a fracture of the distal end of the radius intra-articularly, and the lip is volar because this is the thumb. It's a volar lip. It's basically a volar button. I mean, if you're still confused, look at this. Distal end of the radius, intra-articular fracture. Distal end of the radius, intra-articular. You can clearly see that the carpal bones are subluxated volarly or ventrally. This classically happens in volar Barton's fracture. Now, what do you know about Barton's? Barton's fracture is an intra-articular fracture of the distal end of the radius. I've told you this. Just remember that the distal end of the radius is the only bone that articulates with the carpal bones. And if you look carefully, there is a lip around the rim around the distal end of the radius. Lip or rim that will give you the concavity of the distal end of the radius. Now, when there is an intra-articular fracture, obviously a part of the lip or rim is also fractured. So when that happens, the carpal bones subluxate with it. Either if there is a dorsal Barton, the carpal bones will subluxate dorsally, and if there is a volar Barton, the carpal bones will subluxate volarly. Clearly you can see here, these are the carpals that will be there here, and because of the fracture fragment dorsally weak, the carpals will displace dorsally, and in volar Barton, the carpals will displace volarly. You can clearly see this is a volar Barton and the carpals have subluxated volarly. And this is the ring or the rim that I was talking about shown in the image. So technically, what is Barton's fracture? It's a fractured distal end of the radius with intra-articular extension, and there is a disruption of the distal end of the radius rim or the lip, leading to carpal bone subluxation. So essentially, by definition, it's an intra-articular fracture with carpal subluxation. And since it's an intra-articular fracture, what is the treatment? Open reduction, internal fixation with plates. And finally, can you diagnose this? This is the intra-articular fracture, but an isolated radial styloid fracture, radial styloid fracture. This is known as your Schoffer's fracture. Now, what is the story behind Schoffer's fracture? Every named fracture or eponymous fracture has a story. And if you try to know the story, you will know what that fracture is, and then you will not have to memorize it. So Schoffer is basically a French word for drivers. So in olden era, the drivers used to start the cars with a handle that was there in front of the engine, right? So this was the handle there. Can you see this handle? Can you appreciate this handle that is there attached to the engine? And the drivers would rotate this handle to start the engine. And once the engine started, this handle would keep on rotating and sometimes accidentally come back or hit the radial styloid. So this radial styloid would be fractured by the handle of the engine. This is known as your Schoffer's fracture, because this was a fracture that was seen in Schoffer's in those days, right? So the isolated radial styloid fracture seen in Schoffer's, seen in drivers who would start the cars with the handle. So isolated radial styloid fracture, the Schoffer's fracture, Hutchinson fracture, or a backfire fracture. So everything that I've said is written here. So can you tell me the treatment? Intra-articular fracture hai, to logic to open reduction, internal fixation with plates. Finally, moving on to the carpal bones. I'm sure all of you are familiar with all the carpal bones that are located here. And we have a mnemonic, right? She looks too pretty, try to catch her. What do you have? Scaphoid, lunate, yes. Triquetrum, yes, pisiform. Trapezium and trapezoid. Trapezium, trapezoid, capitate and hamate, right? So these are the carpal bones. A few MCQs, basic MCQs that are asked in anatomy. Which is the most commonly fractured carpal bone? The answer is scaphoid. Which is the most commonly dislocated carpal bone? The answer is lunate. And when lunate dislocates, which nerve commonly gets injured? It's the median nerve that gets injured. Which is the largest carpal bone? The capitate. Which is the smallest carpal bone? The pisiform. Which is the first to ossify its capitate around 2 months, which is the last to ossify its pisiform around 12 to 13 years of age. Okay, so these are the kind of basic MCQs that are expected of you from anatomy. We'll be talking about the most commonly fractured carpal bone, that is scaphoid. So look at this X-ray. Can you see this is your scaphoid at the distal end of the radius, and it has fractured here. So which part of the scaphoid has fractured? So technically scaphoid is divided into 3 parts, the distal pole, the proximal pole, and the waist. Okay, these are the 3 parts of the scaphoid. The most common fracture occurs at the waist of the scaphoid. Now, before we proceed further, I want you to understand what is the story behind this fracture. How does it present to you clinically? This will usually be a young adult, particularly adolescent or young adult, who comes to you with a history of a fall on an outstretched hand. Now, the classic complaint of this individual would be pain and tenderness or fullness in the anatomical snuff box. This is the key word here for this question, anatomical snuff box. When you press on it, it's tender. Now, you would get an X-ray by taking the standard AP and lateral views. Usually, scaphoid fracture is not visible on AP and lateral views. So you would try to get a special view, that is the oblique wrist view. Now, in oblique wrist view also, most of the times the fracture is not visible. It is usually visible 2 or 3 weeks later. So the diagnosis becomes difficult. So your diagnosis is mostly clinical. So look for pain, tenderness and fullness in the anatomical snuff box. It is usually scaphoid fracture. If you want to visualize the fracture, best go for an investigation that will pick up hidden fractures. What is that investigation for occult fractures? MRI, right? Otherwise, wait 2 to 3 weeks to get an X-ray done. But the problem is, the vascularity of scaphoid is very precarious, and I'll discuss that in a bit. The vascularity of scaphoid comes from distal to proximal. So look at this. Say this is your scaphoid. This is the distal end of the radius. The vascularity of the scaphoid comes from distal to proximal. So if there is a fracture of the waist of the scaphoid, what happens is the vascularity of the proximal pole gets compromised. So the proximal pole goes into a complication known as avascular necrosis, and we have read this in basics. And the scaphoid fracture may undergo non-union. So these are two dangerous complications of scaphoid fractures, non-union and avian. So in order to avoid these complications, even if the fracture is not visible on X-ray, we assume it is a scaphoid fracture based on the history of trauma and the location of pain. And what do? We manage it conservatively even if the fracture is not visible. Right? And so how do you manage it? You manage it with the scaphoid cast, which we'll talk about in a bit. Okay. So most common carpal bone to fracture, mechanism of injury is a fall on an outstretched hand. Young adults, adolescents, pain and tenderness in anatomical snuff box. Very, very important location. This is your anatomical snuff box. X-ray, AP lateral views, oblique view is used sometimes, but it is the best view. Although it is the best view, the fracture may not be visible sometimes for up to 2 to 3 weeks. So the investigation for hidden fracture or occult fracture can help you make a diagnosis. That is MRI. I've told you the vascularity is from distal to proximal. And if there is a fracture of the waist of the scaphoid, the proximal pole will go into avascular necrosis. Okay. Now, what is the most common fracture of scaphoid? The most common is waist of the scaphoid. Very good. Now, what about in children? In children, it is the distal pole. In children, this is the most common fracture in children. Now, if there is a waist of the scaphoid fracture, which part of the scaphoid will go into avascular necrosis? Proximal pole. Proximal pole will go into avascular necrosis. Okay? 3 MCQs. 4th MCQ. What is the most common complication? Again, everything is written. Just listen. What is the most common complication? Non-union. Yes, non-union more than avian. Yes, non-union more than avian is the most common complication. So look at this. Fracture of the waist of the scaphoid is the most common. Fracture of the distal 1/3 is most common in children. Most common complication of the waist of scaphoid is non-union more than avascular necrosis, and it occurs mostly in the proximal pole. Now, fracture of the proximal 1/3 has the highest chances of non-union in avian. What basically this statement means is, among the two fractures, that is the fracture of the waist of the scaphoid and the proximal pole fracture, waist fracture versus proximal pole fracture, of these two, which fracture has highest chances of avian? This fracture has higher chances of avian because the fracture is very, very far away from the blood supply. Very far away. Whereas this fracture, although is far away from the blood supply, but still in a good supply zone. Both of these fractures will undergo non-union and avian, and both of these fractures will have avian in the proximal pole. But of the two, which will have higher chances of non-union and avian, this C will have higher chances of non-union and avian because it is a very, very far away fracture. Very, very far away fracture. Because it's the farthest away from the blood supply. Are you following me? So waist of the scaphoid, proximal pole of the scaphoid, both will undergo avian and non-union. Of the two, which has higher chances? Proximal pole fracture has higher chances because it's farthest away from the blood supply. Okay? Did you understand this? And if avian occurs in waist of a scaphoid fracture, which part will go into avian? Proximal pole will go into avian. Again here, proximal pole will go into avian. Of the two, which has higher chances of avian? C has higher chances of avian. Of the two, which has higher chances of non-union? C has higher chances of non-union. Is that clear? I've put it in words for you. Most common site of fracture is the waist of the scaphoid. Most common complication is non-union more than avian. Which part will most likely go into avian? The proximal part of the scaphoid, because it's the farthest away from the blood supply. Which fracture has the highest chances of avian and non-union? The proximal pole fracture more than the waist fracture. Are you understanding? Very good. Now, how do you manage this? If the fracture line is not visible and you're clinically suspecting it to be a scaphoid fracture, you will use a glass holding cast. A glass holding cast where the wrist is in dorsiflexion and radial deviation is called a glass holding cast, where you pretend to hold a glass. And if it's a displaced fracture, you can surgically fix it with a Herbert screw. I'll show you what that is. So undisplaced fracture, a glass holding cast is used, and if it's a displaced fracture, you go for open reduction internal fixation with Herbert screw. It's a fine small screw that you use to fit a scaphoid, or you use to fix a scaphoid fracture. Okay, so quickly review. The most common location for scaphoid fracture is the waist. In children, it's distal pole. And if there is a waist fracture, the most common complication is non-union more than avian. And if avian occurs, it occurs in the proximal pole of the scaphoid. Now there is a proximal pole scaphoid fracture also, but it has the worst prognosis of all the scaphoid fractures. It has the highest chances of non-union, it has the highest chances of avian, because it is the farthest away from the blood supply, that is precarious distal to proximal in scaphoid. Is that clear? Undisplaced scaphoid fracture treated by scaphoid cast, that is handshaking cast. Displaced fracture is treated by open reduction internal fixation with Herbert screw. X-rays are usually AP, lateral and oblique wrist view. Usually they are not positive or visible for X-ray. You can go for an MRI if you want to. Otherwise, treat it like a scaphoid fracture based on your clinical diagnosis of pain and tenderness and fullness in the anatomical snuff box following a fall on an outstretched hand in a young adult. Now moving on to the carpal instability and injuries. So look at this. This is an AP view and this is a lateral view. What do you notice in AP view? This is the distal of the radius, which is articulating with the scaphoid and lunate, and this is the distal of the ulna, which is not articulating with the carpal bones. And there is an MCQ here in anatomy. Ulna does not participate in the wrist joint. Please remember that. In lateral view, this is again the distal of the radius, and this is your lunate, and this is your capitate. So radius, lunate, and capitate usually are in one alignment. Now the first problem that we're going to talk about is the increased distance between scaphoid and lunate. This is known as scapholunate dissociation. Let me tell you what this is. There is a ligament here between scaphoid and lunate known as the scapholunate ligament. If there is any injury to this ligament, what happens? The carpals will start to become unstable and the gap between scaphoid and lunate increases. Normal gap is less than 2 mm. But in scapholunate dissociation, it increases to 3 to 4 mm. Now, what does this finding imply? This finding implies that there is a carpal instability. That's it. That's all it is that you need to know. Now, radiologists, when they look at this gap between scaphoid and lunate, they have described with a term. This term is Terry-Thomas sign. They've called it as Terry-Thomas sign. Why? Because, I don't know, some radiologist somewhere looked at this gap between scaphoid and lunate and thought to himself that doesn't this gap between scaphoid and lunate look like the gap between this gentleman's teeth? And they thought of it. And apparently this gentleman is Terry Thomas, a very famous comedian in Hollywood long time ago, before I was born, let alone you. So long time ago. And so the radiologist thought of this gap between scaphoid and lunate as this sign, Terry Thomas sign. That's all there is to know. So please remember, scapholunate ligament is there between scaphoid and lunate. Injury leads to the increased gap between scaphoid and lunate. This is known as scapholunate dissociation. The gap is more than 3 to 4 millimeters. The radiological sign is Terry-Thomas sign. Okay. Now, if this carpal instability is unattended and there is no treatment that is applied to it, what will happen is the carpals will start to dislocate. So there are two types of carpal dislocations. One is a lunate dislocation, the other is a perilunate dislocation. Please remember that perilunate dislocation is more common than lunate dislocation. Please remember, perilunate dislocation is more common than lunate dislocation. Now, if you recall, I've told you in the lateral view, the radius and the lunate and the capitate, they all fall in a straight line. Now, in lunate dislocation, only lunate pops out of this alignment. Okay, so lunate dislocation, lunate pops out of this alignment, and this is described as a spilled coffee cup sign or a spilled tea cup sign. Again, everything is written, just pay attention. In perilunate dislocation, the radius and lunate remain in alignment, but the carpals either dislocate dorsally or volarly. This is known as perilunate dislocation. So let me show you. So lunate dislocation versus perilunate dislocation. Perilunate is much more common. In lunate, isolated lunate is dislocated. So this is known as spilled coffee cup sign, whereas capitate and radius remain in alignment. Whereas in perilunate dislocation, the lunate and the radius remain in alignment, whereas the carpals dislocate dorsally or volarly. This is your lunate versus perilunate dislocation. That's all you need to know. Now, moving on to the fractures in the hand. We have already finished the distal of the radius. We have talked about the carpal bones. Now we are in the metacarpals. We're starting with the first metacarpal. This is the first metacarpal, thumb, right? So we're talking about the first metacarpal base fracture. There are two important fractures here, Bennett and Rolando. Bennett and Rolando. Before we talk about it, quick review here. This is the first metacarpal, second, third, fourth and fifth metacarpal. The first metacarpal articulates with which carpal bone? Can you tell me what is this carpal bone here? Trapezium. Trapeziometacarpal joint. This is the trapeziometacarpal joint. It is trapezium. Okay. This is scaphoid. This is trapezium. Alright. Can I erase this for you? This is trapezium. Okay. So this is the trapeziometacarpal joint. We're talking about that. So the two fractures here are Bennett and Rolando. Both of these fractures have certain common things and both of these fractures have certain different things. So let's see what they are. So both of these fractures are fractures of the base of the first metacarpal. At which joint? Trapeziometacarpal joint. So both of them are intra-articular fractures. Again, everything is written. Both of them are intra-articular fractures. So what are the common things between Bennett's and Rolando's? First, both of them are base of the first metacarpal fractures. Both of them are intra-articular fractures. Intra-articular which joint? Trapeziometacarpal joint. Okay. Now there is a muscle called abductor pollicis longus which comes and inserts at the base of the first metacarpal and it pulls the metacarpal. Now in Bennett's fracture, because it's a partial intra-articular fracture, what happens is the fracture fragment remains in alignment with the trapeziometacarpal joint, but the remaining metacarpal dislocates because of the pull of the abductor pollicis longus. But in Rolando's fracture, it's a comminuted fracture. And even though the abductor pollicis longus is pulling, it only pulls away this small fragment, sparing the action on this full metacarpal. So there is no dislocation in Rolando's fracture, but there is displacement or dislocation in Bennett's fracture. Is that clear? So Rolando is complete comminuted undisplaced fracture, whereas Bennett is incomplete partial displaced fracture. So let me make it easy for you. Both of them are intra-articular fractures. Both of them occur at the trapeziometacarpal joint. Both of them have strong pull of abductor pollicis longus. But since Bennett is partial, the small fragment remains attached to the trapezium and the remaining metacarpal gets displaced. So it's a displaced fracture. And in Rolando, it's a complete comminuted fracture. So the small fragment is pulled by abductor pollicis longus, sparing the pull force on the metacarpal. So undisplaced fracture. Okay, so look at this X-ray. This is the first metacarpal. This is the trapezium. There's a fracture here, which is partial, incomplete, and this pull will be acting on it. This is your Bennett. And here, this is the comminuted T or Y-shaped fracture of the base of the first metacarpal. This is Rolando, which is undisplaced fracture. Is that clear? Now look at this. Can you see an abnormality here? Yes, there is a fracture here. Yes, there is a fracture here. Yes, there is a fracture here. What is this fracture? This is a fracture of the fifth metacarpal. Intra-articular, extra-articular? Extra-articular. What is this? This is your boxer's fracture seen in boxers, right? So what is boxer's fracture? Fracture neck or extra-articular fracture of the fifth metacarpal. Fracture neck or extra-articular fracture of the fifth metacarpal seen in boxers. How do you manage it? You manage it with a plaster known as James plaster. Well, it is a plaster which is applied in position of safe immobilization. We call it POSI, position of safe immobilization of the metacarpals. There is slight radial or radial deviation of the wrist, flexion of the MCP, extension of the PIP and DIP. Okay, slight wrist extension, flexion of the MCP, extension of the PIP and DIP. This is the position of safe immobilization. Now let's talk about mallet finger and jersey finger. Now before we talk about that, quickly review the anatomy here. So look at this. So this is your distal phalanx and this is the middle phalanx, proximal phalanx, and this is the metacarpal. Now what is this joint, friends? This is the metacarpophalangeal joint. This is proximal interphalangeal joint. Proximal interphalangeal joint, and this is the distal interphalangeal joint. Now, what is the tendon that comes and inserts at the base of the distal phalanx on the dorsal side? It is your extensor digitorum communis. And the tendon that comes and inserts at the base of the distal phalanx on the volar side, it is flexor digitorum profundus. Now, if there is a hyperflexion injury of the DIP, what will happen is that this EDC will either tear in the substance or it might get avulsed from the base of the distal phalanx on the dorsal side. Or if there is a hyperextension injury of the DIP, what will happen? either the FDP will tear in the substance or it will get avulsed from the base of the distal phalanx on the volar side. Okay, can you appreciate this? If there is a hyperflexion injury, the EDC gets avulsed or gets torn in the substance. Or if there is a hyperextension injury, the FDP will get avulsed or there is a tear in the FDP substance. So whatever it may be, what is the clinical outcome? The clinical outcome of tear of EDC is mallet finger. And how will the patient present to you? The patient will present to you with inability to actively extend the DIP. But passive extension would be fine. And how would a patient with jersey finger present to you? A jersey finger patient would present to you with inability to actively flex the DIP, but passive flexion is fine. When you get an X-ray of either of these injuries, if the tear is in the tendon, you will not see anything. But if there is an avulsion, you will see a small chunk of bone avulsed from the base of the distal phalanx. On dorsal side, in mallet finger, and on volar side, in jersey finger. Okay? So those are the points. But listen to me. How do you get this injury? Suppose you had your finger actively extended, DIP actively extended. Now some ball comes and hits you, where there is a hyperflexion injury of the DIP. What will tear? Your EDC. You'll get mallet finger. Similarly, if you had your DIP actively flexed and a force passively extended it, when does this happen? When you hold on to a jersey of another player while he's running. If he's running fast, if you hold on to his jersey, what will happen? Your DIP will extend. So there is a hyperextension injury leading to the tear of the flexor digitorum profundus tendon in the substance, or it will get avulsed from the base of the distal phalanx. That is when you get your jersey finger. ठीक है? Clear है? Now write down the points. Mallet finger, also known as baseball finger. Avulsion of the extensor digitorum communis. Clinical feature, flexion deformity of DIP with inability to extend. Mechanism of injury, hyperflexion injury. Tear in the substance or get avulsed from the base of the distal phalanx on the dorsal side. Treatment is mallet splint or Stack's splint. This is the clinical feature. This is mallet splint. Right? Very good. Jersey finger, avulsion of the flexor digitorum profundus. Either tear in the substance or avulsion from the base of the distal phalanx on the volar side. Clinical feature, extension deformity of the DIP joint with inability to flex. Mechanism is hyperextension injury, as in holding someone's shirt or jersey while they run away. Treatment, you can again use a frog splint. Frog splint. Let me show you the X-rays of these avulsions. So this is the dorsal side, and there is a small bony piece avulsed from the dorsal side. What could this be? This is your mallet finger. Is this clear? A very important image. Mallet finger will definitely show up on your exam. Please be ready to answer this. And please remember, don't get confused between the deformities that you see in mallet finger versus the deformities that you see in rheumatoid arthritis. In rheumatoid arthritis, multiple fingers will be involved. Multiple joints will be involved. But in mallet finger, only one finger is involved, the one that is injured. Another interesting fact that I want you to remember is mallet finger usually occurs in the index finger, and the ring finger usually is affected by jersey finger. Okay, so jersey finger is ring finger, mallet finger is index finger. Now with that knowledge, we have covered everything that we needed to cover in the trauma of upper limb. Let's practice a few MCQs and see if we have understood this vast and important topic or not. So let's look at the first question. A 30-year-old female fell on an outstretched hand while riding a bike. She complains of wrist pain and tenderness in anatomical snuff box. She has restriction of wrist movement. Attached is the X-ray image. What is your diagnosis? Now, before even looking at the X-ray, do you have a diagnosis in mind? Yes, based on anatomical snuff box tenderness. Yes, what is your diagnosis? Your diagnosis is scaphoid fracture. You have that clinically. But let's look at the options and also the image. The image, clearly you can see that there is a fracture of the scaphoid. Okay, very good. Options are transverse scaphoid fracture with perilunate dislocation, or is it scaphoid fracture, Smith's fracture and hamate fracture? Smith's fracture out of the question. It's not hamate fracture. It is definitely scaphoid fracture. That is the answer. It is not scaphoid fracture with perilunate dislocation, because if you recall, I told you lunate versus perilunate dislocation. The radius, lunate and capitate are usually in alignment in lateral view, and in lunate dislocation only lunate dislocates out. And in perilunate dislocation, lunate and radius remain in alignment, and the carpal bones, including the capitate, either dorsally or polarly displaced. Can you tell me the radiological sign, the named sign for lunate dislocation? Spilled coffee cup or teacup sign. A 11-year-old boy came to the OPD with deformity in his left elbow. What is the most likely injury to cause this deformity? So what is the deformity? It is cubitus varus deformity. Carrying angle has been decreased. Bowman's angle has increased. So what is it? It is supracondylar fracture of the elbow. Without wasting any time, that is the diagnosis. Okay, very good. What type of fracture is shown in the X-ray? This is an X-ray showing you a proximal humerus surgical neck fracture. So what type of fracture is it? Is it Neer's type 2 proximal humerus fracture? Is it Gardner's type 2 proximal humerus fracture? Is it Schatzker type 2 proximal humerus fracture or Gustillo type 2 proximal humerus fracture? Gustillo-Anderson's for open fracture, Gardner's is for neck of femur fracture, Schatzker is for proximal tibia and a lot of fractures around the elbow, but Neer's is the classification I've told you that is we use for proximal humerus fracture. So the answer here is A. Remember, Neer 1 is an undisplaced fracture, Neer 2 is a 2-part fracture, Neer 3 is a 3-part fracture, Neer 4 is a 4-part fracture, and it has highest chances of avascular necrosis and it has worst prognosis. And the 4 parts are head of the humerus, GT, LT, and the shaft of the humerus. What is the diagnosis of this fracture? So it's a spot MCQ. If you can diagnose this, only then you'll be able to answer. Otherwise, no point. So this is the radius, which looks like it is dislocated, and there is a fracture of the ulna. It's definitely Monteggia fracture, right? It's not sideswipe, it's not Galeazzi. So which Monteggia is it? Based on Bardo's classification, since the radial head is dislocating anteriorly, it is type 1 fracture. Recall Bardo classification. In all of them, ulna is fractured and all of them radial head is dislocated. In type 1, it is dislocated anteriorly, type 2 dislocated posteriorly, type 3 dislocated laterally, and type 4 it's dislocated anteriorly with a fracture of the radius. Most common type is type 1. Now let's look at this question. A patient with a history of recurrent posterior dislocation of humerus was evaluated. Which part of the head of the humerus will you expect the lesion of humerus to be on? Okay, so what are they essentially talking about? Posterior dislocation of humerus, lesion of the humerus, they're talking about the Hill-Sachs lesion. So in posterior dislocation, where will you get the Hill-Sachs lesion? Posterior dislocation, where will you get the Hill-Sachs lesion? Right, you will get it on the anteromedial aspect of the head of the humerus, right? So the answer should be anteromedial aspect of the head of the humerus. Please recall, in posterior dislocation, the anteromedial aspect of the head of the humerus will come and hit the glenoid to get an indentation or excavation. That is your reverse Hill-Sachs lesion. Can you tell me what is reverse Bankart lesion? Reverse Bankart lesion is the glenoid labrum avulsion from the posterior inferior margin. Whereas the normal Bankart and normal Hill-Sachs is anterior inferior margin in anterior dislocation, and normal Hill-Sachs is normal Hill-Sachs, right? Yes. So when the head dislocates anteriorly, comes back and hits like this. Which part? Posterolateral part. Posterolateral. ठीक है ना? So reverse Bankart is posterior inferior. Normal Bankart is anterior inferior. Normal Hill-Sachs is posterolateral. Reverse Hill-Sachs is anterior medial. Is that clear? Did you understand? Unless and until you observe this, you will be unable to appreciate it. There'll always be this confusion. But please remember, Bankart's and Hill-Sachs, very importantly, Bankart's is anterior inferior margin and Hill-Sachs is posterior lateral margin of the head of the humerus. Okay, very good. Next question. Which proximal humerus fracture has the highest chances of AVN? 1 part, 2 part, 3 part, 4 part? According to Neer's classification, it's 4-part fracture which has the highest chances of avascular necrosis. Now, a patient with closed spiral fracture of the humerus shaft came to the emergency department with wrist drop. Means there is a radial nerve palsy. Fracture was reduced and splinted by a junior doctor on duty. Wrist drop still persists on 1 week follow-up. What should be the next line of management? It's only been 1 week. It's a neuropraxial injury. We've discussed this. Only wait and watch? Yeah, you can wait and watch. Surgically explore immediately? Absolutely not. Wait for 1 to 3 months for recovery. Do EMG and if required, do surgery then. Yeah, seems like a very thought out plan. Remove the cast, do nerve conduction studies and post for surgical exploration. Very aggressive. No need to do this. The best answer here is C. And I've already told you this. Shaft of humerus fracture. Radial nerve injuries are usually neuropraxias that can be conservatively managed with a cock-up splint. Usually they recover fully in 3 months. The splint that you will use is cock-up splint in wrist drop because of radial nerve palsy, and the algorithm that I have given you, fracture with radial nerve palsy, usually neuropraxia. It will recover, and if it is recovering, you just wait and watch and there is no need to interfere. Just give the cock-up splint. If it is not recovering by 3 months, go for a nerve conduction studies and see what's going on. If it is recovering in the nerve conduction studies, again, there is nothing to do. Wait and watch. It will will recover within a few months. If it is not recovering on nerve conduction studies after 3 months, then you have to go for surgical exploration. Right? Next. True about supracondylar humerus fracture is: distal fragment is most commonly dislocated anteriorly. It's talking about flexion type. No. Extension type is more common. Cubitus valgus malunion is more common than cubitus varus. No. Cubitus varus is more common. Causes weakness of elbow flexion. No, elbow flexion should be fine. It's an extra-articular fracture, so that is not the answer. Nerve injury manifestations are transitory. Yes, nerve injury manifestations are transitory. These are anterior intraosseous nerve injuries more than median nerve injury. So I will go with D as the best answer for this question. The first sign of Volkmann's ischemia is Volkmann's ischemia, right? So they're talking about compartment syndrome. Paresthesia, no. Pain on passive extension of the fingers. Pain on active extension of the fingers. Swelling of fingers. Not swelling, not paresthesia. It's definitely pain on passive extension or pain on passive stretch of fingers. Please remember, pain is the most important sign. Pulselessness is the least important sign. It's the latest sign. And in an unconscious patient, you diagnose it with a manometer. The normal pressure is less than 10 millimeters of mercury. More than 30 is diagnostic of compartment syndrome, absolute pressure. And the delta P, the differential pressure, is diastolic minus compartment pressure, should be less than 30 to make a diagnosis. Most prominent part on examination of elbow in posterior dislocation of elbow. If there is a posterior dislocation of elbow, which will be the most prominent part that you can palpate? Radial head? No, because it does not participate in elbow dislocation. Elbow dislocation is ulnohumeral dislocation. Coronoid? No, it is olecranon, right? It is olecranon because that is the most prominent part in elbow dislocation. And also tell me, what happens to the 3-point bony relationship in elbow dislocation? It will be reversed, yes. Myositis ossificans occurs most commonly around which joint? Elbow joint more than hip joint. So the answer here is elbow. A 3-year-old boy comes with pain at the elbow after being suddenly jerked at the forearm. He is crying and holds the forearm in pronation and refuses to move the limb. What is the appropriate management at this age? Classical history. What is this? Pulled elbow. Examine the child under GA. Elevate the limb and observe. Apply Dunlop traction. Flex the elbow and supinate. Flex the elbow and forcefully supinate. The head will go back inside. That is the best answer. Can you tell me Dunlop traction? Where is it used? It's used in compound or comminuted supracondylar humerus fracture. Very good. Pin is injured in posterior intraosseous nerve, which a branch of radial nerve is injured in. Posterior dislocation of elbow, no. Ulnar nerve is injured. Reverse Monteggia fracture, it's Galeazzi fracture. Monteggia fracture, yes, it's ulnar fracture with radial head dislocation, and this can injure pin. Supracondylar humerus fracture, no, it's anterior intraosseous nerve more than median nerve. So answer here is C. Straightforward. Also, what is the most commonly injured nerve in shoulder dislocation? Axillary nerve. Axillary nerve. Most commonly injured nerve in shaft of humerus fracture, Holstein-Lewis fracture, radial nerve. Very good. Colles fracture is associated with all except. Okay. Common fracture in postmenopausal elderly, true statement. A posterolateral displacement of distal fragment. Distal fragment goes posteriorly and laterally, yes, true. Impaction and shortening, yes. Posteromedial displacement of the distal fragment, no, this is false. The distal fragment goes posterolaterally. What is the displacements of Colles fracture? Dorsal tilt and shift, impaction, lateral tilt and shift, and supination. The mnemonic is DILS, very, very important for your exam. Okay, so dorsal tilt and shift, impaction, lateral tilt and shift, and supination. These are the displacements for Colles fracture. Position of wrist in Colles cast. In Colles cast, which position? Position in Colles cast is pronation, ulnar deviation, and flexion. So the best answer is palmar deviation and pronation. Right? Hand shaking cast. Hand shaking cast. The cast is below elbow. Right? So pronation, ulnar deviation, and palmar flexion. Hand shaking cast. That is the position. Barton's fracture is intra-articular fracture of the distal end of the radius with carpal subluxation. Let's look at the option. Fracture distal end of the radius sounds about right. Extra-articular, no. Intra-articular fracture distal end of the radius, yes, sounds about right. Intra-articular fracture distal end of the radius with carpal subluxation, yes, this is the best answer. Okay, so please understand that the options can be close, but we have to choose the best possible answer. One of the common fractures that occur in boxers while punching their opponent with a closed fist. Monteggia fracture, Galeazzi fracture, Smith's fracture, Bennett's fracture. There is no boxer's fracture, right? The answer here is Bennett's fracture based on the options available. That is the fracture that you will get in boxers. Symptoms of Sudeck's dystrophy are all except pain, sweating, stiffness, increased bone density. The answer is increased bone density. For people who don't know what Sudeck's dystrophy is, it's basically a part of complex regional pain syndrome. It can occur because of either a fracture, a soft tissue injury, or a nerve injury, or even after prolonged immobilization. It has been divided into type 1 and type 2. Type 2 is usually following nerve injury. But at the end of the day, please understand the outcome is similar, whatever the cause may be. The outcome is that there is an abnormal excessive sympathetic discharge. So there is an abnormal excessive sympathetic discharge, because of which there is hyperemia, increased vascularity, swelling, edema, a loss of hair, anhidrosis or hyperhidrosis. There will be thickening of the skin, shiny or trophic changes on the skin, and this usually occurs following a trauma, particularly around the wrist and the foot. Hyperhidrosis or anhidrosis, tropical changes of the skin, discoloration or disuse, atrophy of muscles, and atrophy of bones is very important. So when there is atrophy of bones, what will happen to the density of the bones? It will decrease. So there is osteopenia in reflex sympathetic dystrophy, which is an abnormal idiopathic outcome of a fracture or an injury or a soft tissue injury or a nerve injury, which you do not know the cause of. And the manifestation is abnormal sympathetic activity, leading to hyperemia, leading to decreased bone density, leading to swelling, leading to trophic changes, hyperhidrosis or anhidrosis. Okay, what is the treatment? The treatment is watchful inactivity. It's very painful both for the patient as well as for the doctor, because the patient seems to not get any kind of relief. The doctor is unable to provide any kind of relief. Okay, and it is one of the rare complications of a Colles fracture. Now, the ideal treatment of fracture in the X-ray. So what is the fracture in the X-ray? It is the fracture of the olecranon. The treatment would be open reduction, internal fixation with tension band wiring. Now, Ames question: fishtail deformity seen in which of the following fractures? Distal of the radius, distal of the humerus, distal of the tibia, distal of the femur. You know the answer is distal of the humerus, and you know the most important cause is supracondylar humerus fracture because of the internal rotation or displacement of the fracture. And also one of the rare causes of fishtail deformity is a resorption of the lateral part of the distal humerus. Either way, the cause is at the distal humerus, which can present as a fishtail deformity. Next, an old lady fell and injured herself. She took traditional treatment. After 1 year, she presented with a deformity and pain at the wrist. What is the likely diagnosis? So there was a fall, there was a fracture. She took conventional traditional treatment as in quack or Gerra or whatever. And now she has come to you with this deformity. What is this classical deformity? This is a dinner fork deformity, suggesting it must have been a Colles fracture. So it's a malunited extraarticular fracture of the wrist with dorsal displacement. Yes, possibly. Is it a malunited extraarticular fracture with the wrist in volar displacement? No, this is a Smith. Malunited intraarticular fracture? No. Extensor tenosynovitis? No. So answer is A. It is a malunited extraarticular fracture of the distal end of the radius with the distal fragment going dorsally. This is your classical dinner fork deformity, extraarticular fracture with dorsal displacement. An old lady slipped and fell at home. She was diagnosed with a Colles fracture and managed with a POP cast. What is the correct sequence of reduction? You know this. The correct sequence of reduction, I've showed you the video also. That is traction. Yes, traction followed by palmar flexion, ulnar deviation, and then the application of the plaster of Paris. So traction, palmar flexion, ulnar deviation, and then application of the plaster of Paris. So traction, palmar flexion, ulnar deviation, and then application of the plaster of Paris. Match the name of the fracture with the site. So Jones fracture, Bennett fracture, March fracture, Boxer's fracture. Boxer's fracture is 5th metacarpal. Matches this. Jones fracture is 5th metatarsal. Bennett's fracture is base of the 1st metacarpal. And March fracture is 2nd metatarsal, neck more than shaft. So the best answer is C. Is this clear? So these are all eponymous fracture, friends. You have to remember all the names of the fractures, and every name usually has a story, and I've told you those stories, so it will become easy for you. So Bennett's and Rolando's are fractures of the base of the 1st metacarpal. Bennett's is partial, Rolando is complete. Bennett's is displaced, Rolando is undisplaced. This is 5th metacarpal fracture. This is your Boxer's fracture. Fracture of the base of the 5th metatarsal, particularly between 4th and 5th intermetatarsal articulation, is your Jones fracture. Let me show you the X-ray here. This is your classical Jones fracture at the base of the 5th metatarsal. What is this isolated radial styloid fracture? This is your Schoffer's fracture or Hutchinson fracture or a backfire fracture. A 45-year-old patient with a tibial fracture on cast. Okay, she had a tibial fracture on cast. Presents to the emergency department with complaints of intense pain. Cast was removed, smart, and on examination, passive flexion was painful. Alright, so looks like pain on passive stretch. dorsalis pedis and posterior tibial pulses are palpable. Okay, pulse is palpable, and loss of sensation over the first web space was noted. First web space, loss of sensation. What is the next step in management? Measure the compartment pressure, duplex imaging, venous or color Doppler, reapply the cast, give analgesics. Giving analgesics is just temporary. Reapply the cast, I don't think that is something you should do because the patient is already in compartment syndrome. Duplex imaging, venous, color Doppler, why would you want to do that? You've already done it and there is palpable pulse, right? So there is no point in doing that. Measure the anterior compartment pressure. Yeah, that would be something that you would want to do ideally because it will help you make the diagnosis. Normal compartment pressure is less than 10 millimeter of mercury. More than 30 is diagnostic of compartment syndrome in absolute terms. And if the patient has low BP, you would look for a differential pressure. And if a differential pressure is less than 30, you can make the diagnosis of compartment syndrome. So remember, pain is the most important thing. Pulse is not very important. Even though the patient had pulse, we are not very keen to change our decision or diagnosis based on the presence or absence of pulse. So compartment syndrome, a few important points from Bailey I want you to remember is that the patient, doesn't matter whether the patient had a high velocity or low velocity injury, risk of compartment syndrome is equal in both of them, and compartment syndrome can also occur in open fractures. Now, which of the following findings appear late in compartment syndrome? They are asking the late sign. Pallor, pulselessness, paralysis, or pain on passive stretch. Answer is pulselessness. This is the least important and the latest sign of compartment syndrome. Please also remember, pulselessness is an extremely late sign. Absolute compartment pressure greater than 30 is diagnostic, and a pressure difference or a delta P of less than 30 is diagnostic of compartment syndrome. And I cannot stress this enough. Compartment syndrome is a very important topic for your exam, and it has been asked in almost every exam I have seen in the past few years.